for a conversation in pursuit of health equity. Please welcome Senior Director of the Health Equity Fund, Dr. Marla Dean, Dr. Damon Francis, and Dr. Anthony Iton.
Good morning. Practicing these heels that I haven't been in since before the pandemic. Trying, so don't look at me struggle. Good morning. I am deeply moved by the poetry. I literally lost at one point. With that being said, thank you. I'm so happy to have you here. When I first learned of your work, I said, you must be here. Thank you for coming all the way from California to be with us, to talk with us. I said, if they don't respond, I may have to go to California and find you because we're in for a treat. So let's start. Could you just briefly tell us a little bit about yourselves and the work you're doing? Who would you like to start? Okay.
Good morning, everybody. These chairs are quite unstable, so if I fall over, that's what's happening. So I'm Tony Iton, and I'm a Senior Vice President at the California Endowment, which is California's largest health foundation, and been there for 15 years. And before that, I ran a health department, the Alameda County Public Health Department. And before that, I ran another health department called the Stanford, Connecticut Health Department. And really glad to be here. Damon and I wrote a paper for the Urban Institute that was based on our collective years of kind of disappointment with the healthcare system and how it's constructed. And so we're going to talk a little bit about that today.
Thanks. I'm Damon Francis. I'm the medical director of the Homeless Health Center at Alameda Health System in Oakland, California. I'm a practicing physician, primary care HIV doctor, and in my role as the medical director of the Homeless Health Center, I am actually the head of our community health center that's embedded in the government. So I report directly to our majority consumer board and have been really interested in the intersection of health center governance, democracy, and health. And just really glad to be here with you. I'm so thankful to be welcomed in the way that you all, welcomed us. I think my body feels comfortable, my soul feels recognized, and I just can't stress enough the importance of being welcomed in this way and what it means. So thank you.
So you talked about the paper. We're going to start off with the paper. You were asked by Urban Institute to write a paper called Envisioning a New Health System Rooted in Equity. And you were asked to write an aspirational vision of what a health system focused on health equity as outcomes could look like. Could you please could you please give us an overview of this work and you answered this really important question, envisioning a health equity system. Should I switch mics out? They're well prepared. Okay. So if you could please just give an overview of your paper and the critical points you made in that paper, because it was that paper that made me learn about your work that made me say you needed to be here. So we'll go with that.
Well, I'll say just to start that it was a very difficult paper to write, and we tried on a number of occasions to actually get out of it. It was, the Urban Institute was taking a kind of a look back 20 years to a paper or a series of papers that many of you probably had exposure to called Unequal Treatment, which was an Institute of Medicine, now called the National Academies of Medicine, report looking at the healthcare system and how it fared for people of color. And it was in 2003, and they concluded very assertively that the healthcare system was failing people of color across the spectrum in every possible outcome. And so this Urban Institute series of papers was an effort to take a look back 20 years to see what had changed. And many of the papers are kind of these heavy, rigorous scientific papers that are looking at various aspects of the healthcare system, and they thought that it might be worth having somebody write kind of more of an aspirational piece, looking at, what kind of health system do we actually need? And because of the setting, Damon and I spend a lot of time kind of talking about these things, but the setting in a sort of a rigorous academic kind of way makes it difficult to sort of say some of the things you want to say, because there isn't necessarily kind of like very specific evidence that you need to make these conclusions. These are more the kind of the realizations of living in a society and recognizing the harm that that society does on a regular basis to all of us. So we wanted to write a paper from that perspective. And the first thing that we wanted to address is that health and healthcare are just not the same thing. We know, you heard earlier that roughly 20% of health outcomes are shaped by the healthcare delivery system. Some people think it's less than that. I think it's probably around 10%. But most of what shapes our health has nothing to do with the fact that Damon and I are doctors and have stethoscopes and know how to prescribe some medicines. So much of it is related to opportunity. And the structures that control opportunity, the schools, the way our cities are laid out, the healthcare system itself, the criminal justice system, are shaped by a legacy of practices that were discriminatory, that were intentionally designed. And these weren't just sort of like, oops. These were very much prescribed to injure the opportunity of people of color, most often African Americans and indigenous Americans, very intentionally. And the legacy of that lives with us today. And so we couldn't talk about a healthcare system without taking a hard look back at what shaped the current healthcare system today. I noted your second aspiration there about a non-extractive economy. Our healthcare system is an extractive system. It is the single biggest producer of bankruptcies in the United States. It's a predatory system. Most people are afraid of it because they're afraid of the costs. And on top of that, they're afraid of being discriminated against. So taking on this issue for us, we said we can't just tinker around the edges of this thing. We have to go deep to the root causes and try to understand the history and legacy of how the system came to be. And that's why the paper was difficult, because we had to say some things that we think are very obvious to any objective observer, aren't really talked about in health policy. So let me toss it to Damon there with that little nugget.
And let me also say before you get started, there are plenty of seats over here, so please come up and have a seat and be comfortable. Okay, go ahead.
Yeah, I would say the other thing we were asked to do is find examples, right? And I think that work of imagination, that I think Camilo invited us into, is really important in finding examples. It's different than the work of doing research, which is kind of the structure by which we were edited and sort of asked to bring the paper about. But I think it's really important for all of us to understand that, especially in the work of sort of envisioning a new future, as your health equity committee is doing, that there's sort of a rigor in dreaming. There's a rigor in looking around you and in appreciating the value of the examples that you have in front of you, and in finding the ways that those examples uplift the principles that are important for a vision of the future, because we don't know exactly what it's going to look like. When my ancestors were dreaming of freedom, they didn't know exactly what it was going to look like. It didn't mean they stopped dreaming about it. It didn't mean they stopped working toward it. It didn't mean that they weren't rigorous in their arguments, rigorous in their celebration of success. So we have to find rigor in those kinds of practices as well. And I think we're probably not the two right people to do that, but I think that's what we were trying to do with the work.
So let's talk a little bit about those examples. You really make a point about a social contract. And this is rarely a part of public discourse, but you also cite a lot of global examples where there are stronger social contracts than here in the United States. Can you talk a little bit about what is a social contract and give us some examples of what other people are doing around the world?
Yes, absolutely. So social contract is kind of nerdy rhetoric. You know, some of you are immediately thinking, oh gosh, that sounds socialist. It is not. In fact, the Declaration of Independence is a social contract, very expressly so. A social contract is a simple thing. It's basically a contract between the government and the governed. That, you know, when you're governed, you're essentially giving up some of your rights. And in exchange for giving up those rights, you're asking for some benefits. And the benefits in most countries are policy around healthcare, policy around education, policy around housing. In the United States, there are essentially benefits too, but the description of those benefits is relatively thin. And we have been challenged to try to understand why every single other developed country in the world has the ability to construct a strong social contract. Universal health care, universal child care, universal paid sick leave, you know, benefits that helped them do better than we did during COVID-19 because people could actually afford to take time off and recover, unlike here. Why? Why are we the outliers in this regard? And that was the big question for us, is if we fundamentally want to improve the health status of the United States, we know that the investments have to be preventative. It has to be early investments in opportunity structures like education, like housing, like access to healthcare. However, we don't invest universally in any of those things. And our conclusion, and we're not alone in this has been well documented in many other, you know, various types of literature, is that we still haven't healed the essential wound of racism in this country. We still have a festering wound. Brian Stevenson, who runs the Equal Justice Initiative down in Alabama, talks about how slavery ended, but the narrative never did. And that story of who belongs, who's valuable, who deserves, still permeates our policy. And it essentially creates these tiers of policy, Medicare, Medicaid, you know, various different types of essentially segmented opportunity. And we do that because we dehumanize and we devalue certain populations. And we do it very explicitly. And we don't talk about it. You know, we assume it's a normal thing. And so we wanted to get into that in the paper to highlight the fact that we have a woefully threadbare social contract in this country. It's actually getting thinner, and it has profound health consequences, much greater health consequences than access to healthcare, as an example. So I'll say one last thing on this subject, and it's about universal healthcare. And we make the point that the countries that have the strongest social contracts have a high level of social solidarity. In other words, people see that their fates are inextricably intertwined with others, and they're willing to invest in other people and into the future. In this country, we're not willing to invest in other people because we have a very low level of social solidarity because we still operate under this sort of narrative of essentially differential value for different populations. And that narrative has profound consequences. When we talk about universal health care, the thing that sometimes we forget is that there's two parts of that phrase, universal and healthcare. And the part that actually matters most, and this is going to sound absurd coming from a doctor, is the universal part. The healthcare piece is necessary but woefully insufficient. The universal part is a signal of solidarity. Universal policies signal that we see each other's needs. We see how our fates are connected. And until we can see that routinely and enshrine that in policy, we're going to struggle. we're going to struggle in ways that will make it very difficult for the healthcare system to essentially repair the harm that society does.
You asked a little bit about just examples, of other countries and comparisons. There's a great report that the Commonwealth Fund did, picking up on universal health care and looking really at healthcare systems. So they ranked 11 systems, that are developed countries with strong economies on affordability, on health outcomes overall, on health equity, and on process measures of care. So the United States was second on process measures of care, and we were 11 out of 11 on all other measures. So I often say this, in context where I'm, talking to sort of conservative policy analysts. We aren't 11 out of 11, it's close. Literally any example is better than ours. I don't think we don't have a sort of space in our minds as Americans that we are the absolute unequivocal worst. Even for wealthy white populations, our healthcare system produces very bad outcomes in comparison to other countries. It sort of helps, I think, some members of our society think that they're doing well, that they can look down on others. But if you look across the international context, 11 out of 11 on health, 11 out of 11 on spending, 11 out of 11 on equity. And it's not even close. So, there's places where the government provides health care. There's places where there are heavy regulations of relative to our system at least, of a private market. There are many different ways to do it. You don't have to be socialist, as Tony said. The rhetoric here is sort of, this is this leftist sort of thing, but the reality, if you really look across the world, is we could pick pretty much any example and copy them and do better than we do here.
So, I want you to just explain a little bit more, Dr. Francis, because you said that the health outcomes for wealthy white people are not strong either. Can you talk a little bit more about that?
Yeah, there's a good National Academy of Science, Engineering, and Medicine article called "Poor Health, Shorter Lives" or something like that, that does these comparisons, and with some slivers of exceptions. For example, I think in oncology care and for specific oncology outcomes, the United States health system does better than other countries. But on broader measures of mortality overall, of function overall, of infant mortality, maternal health measures, the entire United States, inclusive of, if you just looked at wealthy white populations, does worse than other countries. So that's really well documented, in the research. And again, as Tony said, our sort of public discourse it almost rejects and can't recognize how far behind we are on this.
I'll just add to that, and I'm just curious about how many people knew what Damon said was true. If you just raise your hands if you've heard that before. And so relatively few people know this. There's a National Bureau of Economic Research study, which is a bunch of economists, not even health people, from 2018, that looked at essentially white Americans' health stratified by income versus European Union health. And they showed that by 2018, the poorest Europeans have better health status than the wealthiest white Americans. And I'll just say that again, because I want you to take this with you. The poorest Europeans have better health status than the wealthiest white Americans. That's how bad our healthcare system is. I mean, it's so bad that healthcare disparity researchers no longer use whites as a benchmark. White health status is in free fall. It's literally not a good comparison anymore. And it's because of these same forces that we're talking about. Racism has an enormous amount of collateral damage, and it's impacting all of us.
So, what gives you hope? I'm done with the question. What gives you hope?
we had dinner last night and we were saying, we can't talk about some of these things, it's so depressing. Don't want to talk about the election coming up. So I'll start, but then I'm going to pivot to Damon very quickly. So I like to tell people, hi, I'm Tony, I'm from California. That means I'm from the future. And what happens in California today will happen to you tomorrow. And so keep an eye on California because it's essentially your destiny. And what's happening in California right now is giving me a lot of hope. California is grappling with a lot of these questions that we raised in the paper. Trying to redesign our healthcare system. We have, and we're the only state thus far that has included everybody, including undocumented Californians. And that's fairly radical. In some ways, we're pushing up against the limits of sort of federal policy to be able to include everybody in healthcare. We've done an enormous amount of kind of early preventative work amongst populations that have been highly stigmatized, formerly incarcerated people, boys and men of color, again, the undocumented. We've studied essentially the kind of the ecology of the various systems that shape their destiny, and we're re-engineering those systems to invest early in them so that their life trajectories are much higher and comparable to other populations. And we're doing that very intentionally in California. During COVID-19, we used essentially an equity measure to allow different communities to reopen their economies only if the populations that were most vulnerable in those communities had immunization rates, had access to treatment, had disease rates that were within a very small margin of the wealthiest populations. And that was very controversial, but it was an equity measure being applied in real time to affect real people's lives. California has also got a youth movement, and this is where my greatest hope is watching young people take on these issues, organize themselves, and take us on. Because we are guardians of the status quo, whether we like to admit to it or not. We accept things that are absolutely outrageous, egregious, and unacceptable. Young people are not that way. You see it now in the college protests that are happening. They're calling us on an absolute outrage that's happening in the world right now on our watch with our funding. And so my hope is in the young people, in my particular case it's in California, but it's young people across the United States that are showing us what equity looks like, and they're demanding a very different reality.
Just picking up on that, I think young people are also reaching back to history and reaching back to cultural coherence and congruence in a way that I think allows us to bring forward the strong survival lessons of our ancestors from multiple different cultures, right? I think we come from a time where we sort of rejected this idea that there's anything to offer outside of the sort of dominant European techno-capitalist kind of paradigm for how you understand problems and how you work to fix them. And I think, we wrote about some examples in the paper, the Beloved Black Centering project, for example, which happens at Alameda Health System, which is group visits, for pregnant women and birthing people who are African American or Black, and really just leverages Black culture as a way to lift up women and connect them to each other, help them support each other, create a sense of mutuality within our culture as Black people. And the outcomes are undeniable, right? Higher birth weight babies, healthier mothers, they're undeniable, and they come from that linkage to culture. And so seeing people sort of reclaim history, reclaim culture as a means of survival, as a means of health, gives me a ton of hope. And I think our young people are sort of skipping over, some generations to find that, or looking up to us and saying, give us more of that, We know enough of the sort of technical idea of, which medicines you prescribe, but we want to find these sort of deeper ideas of where health and survival come from.
So, you also talked about this very important period, right, with World War II and how America came out of it being, seeing themselves as the hero and Europe seeing those as needing each other and how that impacts our policy today. Can you connect that for us? Because why would World War II impact us today?
Yeah, so we found ourselves writing a little bit about history in this paper, which again was a challenge because we had a bunch of medical editors who apparently don't know anything about history. But trying to explain this, this divergence, how the United States is so different from the rest of the developed world, including Canada, which is literally shares one of the largest borders in the world. Has a lot to do with looking at history. Wow. Okay. I just want to hear what it says next. In World War II, Europe was bombed to smithereens. All right. Europe was bombed to within an inch of its sort of existence, and it was horrifying. I mean, for those of you who like World War II history, I mean, it's just the stories of how close some countries came to no longer existing is quite profound. And a little bit before that, Great Britain had gone through this period of kind of introspection that led to this thing called the Beveridge Report. The Beveridge Report was this. It actually turns out this guy who worked, William Beveridge, who worked in a foundation, the equivalent of a foundation in Europe in the 1930s, wrote this report, which basically said that charity is not enough. We have to have government actively investing in the well-being of the entire population. We have to actually invest in prevention. And it got a lot of traction, and then after World War II, it was converted into policy, and that policy led to the National Health Service and a number of different social policies, including child care and family benefits, universal across the board. Europe, after World War II, signed on to the Universal Declaration of Human Rights, which the United States did not sign on to, which basically held that every human being was entitled to certain types of benefits and protections, which led to a whole host of social protections in Europe and the strengthening of their social contract. And it was because Europe felt vulnerable after World War II and recognized that their fates were intertwined. In the United States, we took a very different message from World War II. We were the saviors of the world. And we basically doubled down on the policies that had gotten us to the point where we were. Now, we had a previous period in our history, which was the New Deal, which was an effort to essentially build out a social contract. They actually contemplated calling it the New Social Contract, but that didn't sound very American, so they called it the New Deal. And the New Deal was, as we all know, that's where we got a lot of sort of social programs that we have today. It very expressly avoided health because of, in some parts, the American Medical Association and doctors at the time who were very hostile to universal health care. But then the civil rights movement picked up where the New Deal left off and tried to bring in, and successfully did bring in, African Americans and other populations that had essentially been excluded from various programs of the New Deal. Again, very intentionally, just read the history. So the US never quite took the same message from World War II that the rest of the developed world took, which was that our fates are connected. The US basically saw itself as the savior of the world and sort of looked at its own policies and policy history as being vindicated by World War II and went on to essentially build out the apparatus that created our healthcare systems that we live in today.
I don't have much to add to that. I think the idea and the salience of whiteness, has really recrudesced in different ways at these different points where we make policy that then lasts for generations. So you can find that in Reconstruction, you can find that in the New Deal, you can find that in World War II, you can find that in the Civil Rights era. And I think it just adds to the point that Tony made earlier, that sort of the original wound is racism, and I think investigating the history with that lens and figuring out how was policy structured in a way, what were the deals that people were making around the time of the New Deal that actually parsed and structurally and pretty directly excluded African Americans or targeted indigenous Americans, I think, looking at the history with that kind of lens is going to continue to be really important, so we don't continue to make those mistakes as we make policy right now.
My concern is, you talk about looking at it through that lens, but most recently we have a couple of congressmen who have said that they introduced a bill to ban DEI in medicine. So I want to know your thoughts about that and what would be the impact if that actually came to pass.
I have tried to understand the bill. I think because it comes from a mindset that uses much different language than I do, I don't really understand what the direct impacts of that would be. And I would say maybe part of what I think is maybe controversial even in this audience, that I think there isn't a lot of evidence that bias training in particular does a lot to improve racial outcomes, to improve health equity. And I do think we need to figure out a way to come together and focus on better outcomes for all of us, and particularly the folks who are the most excluded and most marginalized and have been historically so. And as long as we still have mechanisms to do that, that's where we're going to learn to be better. We're going to learn to be better by welcoming each other in the way that you welcomed us, right? Which says if you have a history of trauma, if your body has been affected in certain ways where you can't close your eyes, you're still welcome here, right? We're going to learn how to do these things by practicing trying to get better, not so much by particular language that we use. I think, it's sort of inconceivable that you could be in a clinic as any kind of a worker and not recognize the impact of racism on the health of the people that you're seeing in that space and legislate away. I mean, it's a sign that we're being successful in integrating this perspective, and I don't want to be too defensive about it because it's a sign of our success in my mind, and I think we need to keep moving in this direction and working together to be better for all of us.
Ditto. We have to fight this. I mean, and it's clearly coming out of places that have a very different agenda than actually improving health. I'm proud to say in California we're doubling down on DEIB, with belonging being critical to it. But I think I'm on the board of a medical school, I think the newest medical school in the United States as of whenever, Kaiser Permanente School of Medicine, and we're amongst the most diverse schools in the country now because it's part of our school's named after an African American leader, Bernard J. Tyson. And it's built into our bylaws that diversity is one of the primary goals of our institution. So ain't no way we're going back on that. It's just not going to happen. But what is absolutely critical, I went to medical school in the 1980s. And at that point, we didn't talk about racism, we talked about race. Race as being basically a socioeconomic variable that basically explained why you had these bad outcomes. And it was just sort of like, oh, well, that's race, and nobody interrogated what that meant. We do that at the Kaiser Medical School. We interrogate what racism means, how it plays out at the individual patient level, at the societal level, at the community level, and that's absolutely critical. But I think that what's probably even more important is what we talked about in the paper. When we look for examples of systems that were built around equity, we found only two that we could point to and say definitively these are equity-focused systems. And they were both indigenous design systems that were built around essentially a very different concept of health. Health being in those systems about connectedness to community, connectedness to land, connectedness to your ancestry, connectedness to animals. I mean, it literally just centered around a very different concept of what health is. And when we compared that to the most successful healthcare systems in the United States today, those systems are all basically built around a corporate model, which is about selling service lines to payers. Selling different, technologies to people who can pay. It has nothing to do with health. Nothing to do with health of the population. There's increasingly less and less local control. These are controlled, in corporate headquarters, run by hedge fund people and financiers. And even that grain of sort of community health that was at the heart of our healthcare system, 50, 60, 70 years ago, it is gone. It is absolutely gone. So this was why the paper was a struggle for us, because what we were pointing to is a system we could find very few examples of, none in the dominant white culture, and that the actual momentum was towards a hyper-corporatization of healthcare, and that's a crisis. And it's getting more and more expensive, and the outcomes are getting worse and worse for everyone. Sorry, we should probably go back, I hope.
So, as we close, I want to say thank you, but I want you to give closing remarks on what you want to impart upon us, make sure we understand. And as we look across the room, the people here are committed to issues of equity and justice, and they work daily on these issues. What would you want to say to them?
I think you're doing it here today, build collective power. You need to build collective power. I think you all have chosen, non-extractive economy as a mechanism to do that. I think I tend to work in the area of public governance. But coming together in spaces like these, refining your analysis and understanding, sharing your different perspectives on the same goal, and doing that in a way that builds power for the people who have the most to gain from the system we're trying to create is really critical. If you're in a healthcare structure, if you're in a public health structure, I think you really have to formulate an understanding of how communal power adds up to health. So one of those examples, that Tony was talking about is the South Central Foundation in Alaska. And they're a remarkable example. They were really dissatisfied with how the United States government, the Indian Health Service, was running their health system. And they bought it, basically, from the United States government and declared themselves the owners of their own system collectively. And they very formally inscribe into how they do everything this idea of customer owners. So they don't really have patients in that system. They have customer owners. And when a customer owner walks in, you are treating an owner of the organization that you work for. But at the same time, the owner actually has obligations to you, right? There's mutuality in that. If you own this, you better make sure that my place of employment is working the right way, right? So this idea of collective ownership has been really powerful. They've won the National Quality Award across multiple industries twice in the last 15 years. The quality outcomes they've achieved in a population that's among the poorest in our country are remarkable. So when we can build power, when we can take back ownership and self-determination of the institutions that determine our outcomes, we can really achieve a lot of dramatic results. And I think you all are on the path here.
That was so cool.
And I would build on what Damon said. We know in this country that your zip code matters more than your genetic code when it comes to your health. And when you look at cities across the country, you see life expectancy differences down to the neighborhood level that are of the order of 15, 20, 25, 30 plus years in the same city, and you can't explain those differences. You cannot explain those differences based on access to healthcare. You can't explain them based on the traditional behaviors of smoking, drinking, driving on seatbelts, whatever. You can't explain it based on genetics. You can explain it based on political power. And that's the message, that the key to building health in this country is about building social, political, and economic power amongst the people who are most impacted by inequity. Health is political, and it requires political action. That means it requires power. It requires organizing. It requires people to essentially hold systems accountable, including the healthcare system, for delivering equitable results. And we take these technocratic approaches to what are fundamentally democratic problems. And until we can optimize democracy, like you're doing here, bringing people together to organize around holding these systems accountable, until we can do that more effectively on a routine basis, we're going to experience the same kind of results. We talk about the key ingredients to this work being three. We call them ABC. A is agency, which is basically power. It's the ability to essentially control what is happening to you, your family, your community, and hold these systems, which are designed to be held accountable by the people that they serve. So agency is critical. The B of ABC is belonging, which is basically the opposite of racism. It's about being seen and heard in your full humanity, about being connected to others, about seeing your face being intertwined with those people around you, and being able to have the story of your ancestors and your community be known to those around you. And then the C is very simple, is rebuilding our social contract. The promises we make to each other to take care of each other when the inevitable SHIT hits the fan in our lives. We know that it's going to happen to all of us, and we can anticipate it. And it's the ability to anticipate human need that makes us human. And so we think it's as simple as ABC in this work. We have a long way to go. There are some great examples happening. This is one of them, and thank you to your work and leadership. But we have to believe what we know in our hearts is true, that our greatest resource in this work is each other.
Thank you. Thank you so much. Thank you for coming all the way from California. Thank you for sharing your wisdom. And you can read the paper if you go to the website. It's there. It's worth your time. Please take the time to read it. Thank you. Okay, it's time for questions. If anyone has a question.
Thank you. Talk about equity. Well, first of all, thank you. I appreciate the conversation. So I work around supporting entrepreneurs with disabilities, and I think it's very prominent to this conversation, right? When we're talking about health equity, because particularly people with disabilities can oftentimes not access healthcare. And so, I guess a two-part question here, but how do you see the role of racial equity and health equity in that space? And then from a policy perspective, what's the intersection between those two things? And to provide more context, specifically my line of work, for example, people with disabilities, if they have more than $2,000 in your bank account, you're at risk of losing benefits, right? And so that perpetuates a cycle of poverty that essentially keeps people with disabilities in a health equity disparity. So curious about how you think about that.
Yeah, I work in homelessness, and so we're really very familiar. I think there's data that shows that people with disabilities are interested in working at exactly the same rate as the general population, and our policies don't make that possible. I think you brought up entrepreneurship. I think policy entrepreneurship is a really important sort of approach to problems like these, which is really a focus on creating something in the world that then serves to demonstrate that we have a better policy, right? And so it's not necessarily focused on the same thing, the same way that like a commercial entrepreneurship, I'm going to create a business that's successful would work, right? So I think community health centers are a good example of policy entrepreneurship, right? Like they were created in the civil rights era. 2 different health centers were created that said, we can actually have a health system that's governed by the patients, and that health system is going to produce better outcomes. And now we have them in all 50 states and US territories, right? They're a foundational element of our system. So I think that sort of approach to entrepreneurship, and I think we're only going to get there if people with disabilities, in the case of what you're talking about, are building those things themselves, right? And if we're funding the ability of people to build those things, Because that's the way that the vision can be expressed, and then we can all see, yes, of course we're going to get behind that.
Good morning. My name is Mustafa Abdul-Samad, and I've been facilitating the Ward 8 Community Economic Development planning process, and we're now looking to implement. Appreciate your comments and your focus on trying to do a collective effort, because I think that's the key. And we're developing a bottom-up approach to dealing with equity, particularly with those populations that are greatest at risk and living in underserved communities. Do you have any model of communities developing a bottom-up process where the residents are really put in a position of influence and being able to control their own destiny? Because from my perspective, there really isn't that many models out there that have been effective. So can you share any models that you might know?
Yeah. First of all, thank you for the work that you're doing, and I know a little bit about the community that you're working in, and I can imagine that has been very interesting and has led to some very significant questions. I had the privilege of running essentially the largest place-based health improvement initiative in the history of the United States. It's called Building Healthy Communities. It's based in California. It was a $2 billion, 10-year initiative in 14 low-income places, not unlike what you're describing, as the environment of your work. And it's been very successful. And it's been successful primarily because of the model that we use, which is the ABC model, which is fundamentally about organizing community and building up power and being a little bit agnostic about outcomes. Focusing on power, because we believe that the people who are closest to the pain of inequity have the best solutions. And this ties into the entrepreneurial model too, is the people that are closest to the problem are also closest to the solutions. And we leave a lot of talent on the sidelines because we don't invest in their ability to essentially innovate to create solutions. So the strategy, we think, and there's a couple of secrets, I kind of alluded to them a little earlier. One is that you only need to organize about 1% of the people in the community to change the status quo. It's a little bit less than 1%. Everybody thinks you have to organize the whole community and everybody has to show up at everything. No, you only need 1%. That will change the dynamics. The second is youth. Youth are rocket fuel for change. Organize young people, and you will see change happen. I guarantee it. And just reflect on our own history. Martin Luther King, Stokely Carmichael, Cesar Chavez, they were in their 20s and 30s when they did, the most powerful civil rights work. Young people are the future. I mean, I like to think of myself as young. I am not, but I like to think of myself as young. At least, my sensibilities are a young person's sensibilities. But I am blown away by what young people can organize and do in community. So feel free to check it out. You can go to our website, the California Endowment. That's called Building Healthy Communities. The results of it, the universal healthcare I talked about was a product of that. We basically eliminated various causes of school suspensions and school expulsions that lead to essentially the school to prison pipeline for African American youth and indigenous youth. We reduced suspensions by about 80% in our large school districts. We changed legislation so that schools can't expel and suspend kids for so-called defiance, these sort of very general catch-all kind of categories. And it's changed not only the number of kids that are being pushed into the criminal justice system, but it's actually raised test scores in these same schools. So organize 1% of people, legitimate organizing now, which takes time, as I'm sure you know very well, but mobilize young people. And focus on narrative. At the end of the day, the stories we tell ourselves about a place, the stories we tell ourselves about our own histories, those are what motivate people or demotivate people. We have to change the narrative about who we are, because there is a white supremacist narrative that says you are not valuable, and that has to be countered.
Excellent. I appreciate it. Thank you.
I'll turn on my New Yorker and speak really fast. My question, I guess, mostly to Dr. Francis, and you mentioned sort of all the horrible failures of the U.S. compared to other countries, and any alternative would be better. Are we in sort of a re-engineering trap in that anything would be better, and so we're not thinking the big imaginative transformative thing that we have a broken employer-based system that's abnormal? So what's the transition process to get us out of the small thinking, the incremental improvements, and to think that this whole thing needs to change?
Yeah, I don't think it's the technical policy choices that we have so much. And I think there's really good work if we want to reference it. If our elected officials and policymakers want to reference it, that's been done by the Commonwealth Fund. I think that's probably some of the best work that's been valuable to me that I've referenced here. So I don't think that we're stuck in terms of those of us who spend time technically kind of thinking about it. I think we're more stuck politically. And so I think it's unfortunately the same answer. I think there is good work to be done on the technical side. I think a lot of folks are still doing it, including on the conservative side. California, like Lonnie Chen, kind of is at a lot of the same sessions that I'm at. Thinking on the conservative side about this, with what are the array of policy options. I think if you are intellectually honest and working on it, it's helpful, no matter what political perspective you come from. I think the problem is that we haven't agreed that we value all lives equally. And until we force that on our society as a whole, we are going to be stuck. I think that's the place we're really stuck.
Okay, so now we really are done. Thank you.